Welcome to this video on mood disorders. We will explore key clinical concepts, the neurobiology behind these conditions, as well as current approaches to diagnosis and management. In this video, we will define mood and affect, examine how these disorders are classified, discuss their biopsychosocial etiology, and outline diagnostic criteria and management strategies. Part 1 of this video covers the foundations of mood disorders, focusing on essential definitions, their clinical classification, and the current epidemiological landscape. To understand these conditions, we must distinguish between mood, a sustained emotional state, and affect, the external expression of emotion. Mood disorders arise when this state becomes dysfunctional and impairs daily life. Mood disorders are psychiatric illnesses characterized by primary mood disturbances. These fall along a spectrum between depression and mania, or hypomania, often accompanied by cognitive and physical symptoms that cause significant distress. Normal mood variations are proportionate to life events and do not impede functioning. In contrast, pathological mood is persistent, disproportionate, and interferes with one's ability to maintain relationships, self-care, and work. Classification systems like the DSM-5 TR and ICD-11 help clinicians identify these disorders. Diagnosis is based on clinical history and the mental status exam, rather than specific laboratory tests. Mood disorders are broadly categorized into depressive disorders, such as major depressive disorder, and bipolar and related disorders, which include bipolar I and II. The global burden of these disorders is significant, with hundreds of millions of people affected worldwide. They are a leading cause of disability, with family history serving as a primary risk factor. Historically, our understanding has evolved from early concepts like Hippocrates' melancholia to the modern, evidence-based diagnostic criteria established in recent editions of the DSM. Part 2 of this video examines the etiology and pathophysiology of mood disorders, looking at the complex interplay of biological, psychological, and social factors. The biopsychosocial model suggests that these conditions are multifactorial. The diathesis stress framework posits that individuals with a biological vulnerability may develop a disorder when triggered by environmental stressor. Genetics play a major role in mood disorders. They are highly heritable and polygenic, meaning multiple gene variants contribute to risk, often interacting with environmental factors. The monoamine hypothesis suggests that imbalances in serotonin, norepinephrine, and dopamine contribute to these disorders. While foundational, it is now viewed as an incomplete explanation for the full clinical picture. Finally, neuroendocrine factors such as HPA axis dysregulation and cortisol levels are key components of the pathophysiology, as are other conditions like thyroid dysfunction, which must be considered in a clinical workup. Moving into neurobiology, neuroimaging reveals reduced hippocampal and prefrontal cortex volumes in recurrent depression. Additionally, the BDNF hypothesis suggests chronic stress impairs neuroplasticity. These findings highlight that depression is a disorder of complex neural circuitry, rather than just simple chemical imbalances. Other factors include the inflammatory hypothesis, which notes elevated cytokines in some patients, and circadian rhythm disruption. Abnormal sleep patterns, such as reduced REM latency and sensitivity to light exposure, are significant, with therapies targeting these pathways showing clinical promise. Psychological factors also drive these disorders. Beck's cognitive triad focuses on negative thoughts about oneself and the future, while Seligman's learned helplessness explains passivity. Furthermore, life stressors and the, quote, kindling effect suggest that repeated episodes may lower the threshold for future recurrences. Part 3 of this video focuses on depressive disorders, beginning with major depressive disorder, or MDD, and related clinical conditions. Major depressive disorder is a serious, common condition defined by one or more major depressive episodes. It is episodic in nature, and because it carries substantial risks, including morbidity and suicide, prompt clinical recognition is critical. The diagnostic criteria for a major depressive episode require at least 5 symptoms over 2 weeks. At least one must be a depressed mood or a loss of interest and pleasure, known as anhedonia. Additional criteria include physical changes like weight fluctuations and sleep disturbance, as well as cognitive symptoms. Clinicians must also ensure these symptoms are not better explained by other medical or psychiatric conditions. To recall the 9 criteria for a major depressive episode, use the mnemonic SIG-E-CAPS, which stands for sleep, interest, guilt, energy, concentration, appetite, psychomotor changes, and suicidal ideation. Diagnostic specifiers add detail to the patient's presentation. These include melancholic, atypical, or psychotic features, as well as anxious distress and catatonia, all of which help guide treatment and prognosis. Onset and timing are also important specifiers. This includes peripartum onset, which occurs during or shortly after pregnancy, and seasonal patterns, where episodes correlate with specific times of the year. Severity is rated based on symptom intensity and functional impairment. Clinicians also distinguish between single and recurrent episodes, as well as the patient's remission status, whether they are in partial or full remission. When diagnosing MDD, clinicians must rule out other potential causes. Differential diagnosis is essential to ensure that symptoms are not due to substances, other medical conditions, or different psychiatric disorders. Regarding prognosis, most untreated episodes resolve within months, but the risk of recurrence increases over time. Maintenance treatment is often needed, and clinicians must monitor patients for the potential emergence of manic or hypomanic symptoms, which would indicate a switch to bipolar disorder. Persistent depressive disorder, or dysthymia, is characterized by a depressed mood lasting for at least 2 years. Unlike the episodic nature of MDD, this condition is chronic, though it can still be highly debilitating. Finally, premenstrual dysphoric disorder, or PMDD, involves severe mood and physical symptoms during the premenstrual phase. Diagnosis requires prospective symptom tracking, and it is treated with targeted approaches, including specific antidepressants or hormonal therapy. Next, we explore disruptive mood dysregulation disorder, or DMDD. This diagnosis, introduced in the DSM-5, identifies children with chronic, severe irritability and recurrent temper outbursts that are disproportionate to the situation, helping to prevent the overdiagnosis of pediatric bipolar disorder. We must also consider depressive disorders that arise due to a general medical condition, like stroke or hypothyroidism, or due to substance use. A thorough medical workup is essential to rule these out, as treating the underlying cause often resolves the mood symptoms. Part 4 of this video turns to bipolar and related disorders. We will examine the distinct poles of mania, hypomania, and the cyclical nature of these mood illnesses. Bipolar disorder is characterized by pathological swings between depression and mania, or hypomania. It typically presents in the late teens or early 20s, is highly heritable, and carries a significantly elevated risk of suicide compared to unipolar depression. A manic episode is defined by at least 1 week of abnormally elevated or irritable mood and increased energy. Key symptoms include grandiosity, a decreased need for sleep, pressured speech, racing thoughts, and high-risk, goal-directed activities. Hypomania shares similar symptom criteria to mania, but differs in severity and duration. It lasts for at least 4 days, causes a noticeable change in functioning without severe impairment or hospitalization, and does not include psychotic features. The primary distinction between bipolar I and bipolar II is the severity of the mood elevation. Bipolar I requires a full manic episode, whereas bipolar II is defined by the presence of at least 1 hypomanic episode and 1 major depressive episode. Cyclothymic disorder is a chronic, milder form of bipolar spectrum illness. It involves at least 2 years of fluctuating hypomanic and depressive symptoms that never quite reach the threshold for a full episode, yet still cause significant instability. Specifiers like mixed features and rapid cycling are critical in clinical practice. They indicate a higher suicide risk and often signal that the treatment approach should prioritize mood stabilizers over antidepressant monotherapy. Bipolar disorder is a chronic, relapsing condition. Depressive episodes are typically more frequent and longer lasting than manic ones. With high rates of substance use comorbidity and suicide risk, long-term management and monitoring are vital. Part 5 covers assessment and risk evaluation. We will look at the mental status examination, the role of standardized rating scales, and the essential protocols for evaluating suicide risk. The mental status exam is key. Observations of appearance, speech, affect, and thought content help distinguish between manic and depressive states. Explicitly assessing suicidal and homicidal ideation in every encounter is a fundamental responsibility. Standardized rating scales provide objective data to track symptom severity and monitor treatment response over time. These tools are indispensable for clinical documentation and ensuring consistent patient care. Investigations are used to rule out medical mimics. Routine tests include thyroid function, electrolytes, and metabolic panels. Neuroimaging or toxicology screens may be warranted in specific cases, such as late-onset presentations or suspected substance-induced disorders. Finally, we must always evaluate suicide risk, which is markedly high in mood disorders. Identifying risk factors, like prior attempts or hopelessness, and protective factors, allows clinicians to provide appropriate care and intervention.